Our plenary speaker this afternoon, Dr. Shukla, Dr. Bela Ostrich. Dr. Shukla is a faculty physician and opioid crisis educator at Mountain Area Health Education and Family Medicine Residency in Asheville, North Carolina. He also serves as an associate clinical professor in the Department of Family Medicine at UNC Medicine. Completed medical school and public health school at Tulane University and completed a residency in family medicine at Montefiore Medical Center in the Bronx. His clinical and academic work focuses on HIV, hepatitis C, transgender health, substance use disorders, marginalized populations, and population health. Bela Ostrich, PhD, is an applied medical anthropologist and community-based substance use, harm reduction, and reproductive health researcher. Dr. Ostrich's research in the past several years has encompassed access to perinatal substance use treatment, the impact of municipal, law enforcement, and healthcare policy on drug users' health, and attitudes toward evidence-based models of harm reduction in rural areas. Dr. Ostrich collaborates with several community syringe access programs in Western North Carolina. They will talk about harm reduction for all, a life-saving, cost-effective intervention. We'll continue the health inequity thread from this morning. So welcome.
Good afternoon, everyone. Can you hear me okay, see me okay, and see my slide?
Yes.
Great, thanks so much. So Bela and I have a lot to talk about, so we'll try to skip through the pleasantries. We hope to have enough time for questions. We hope by the end of the session today, you'll recognize the value of low barrier access to substance use disorder care, especially medication. Buprenorphine specifically is what we'll be focusing on, and particularly in the context of some of the previous speakers today in terms of health disparities based on race or gender. We'll also hope you understand the principles and best practices of evidence-based harm reduction, particularly naloxone distribution, safe consumption services, overdose response and prevention, HIV, hepatitis C screening, and treatment for those conditions as prevention of transmission. And then lastly, we hope by the end you'll learn skills to implement harm reduction principles and interventions in daily clinical and non-clinical practice. So I do a lot of virtual presentations in the past, seems like 7 years, but 7 months. But this is more fun if people have questions. Bela and I have a lot of content in our slides, but we can easily skip over things and just riff on whatever it is people want to talk about. So please use the Q&A and the chat and all those things. So I'll start with just, and Bela and I have kind of cut this into two pieces. I'll start with some of the more clinical and some of the sciencey aspects of this concept of harm reduction and some examples of how that works in my personal clinical practice here in Asheville. So just to start with a patient that I'm actually seeing next week who has at this point been pretty stable with his opioid use disorder on buprenorphine naloxone for about a year, I would say. But particularly in those first few months when I took over his care, actually I started with him, or he started with me. But at that point he was injecting or sometimes smoking methamphetamine. He often used that substance alone, and he actually sometimes injected his buprenorphine combo product. So there's a number of ways a provider might manage this person, and I can tell you how I did this with the spirit of harm reduction. And I'll start by saying harm reduction is something that is embedded into kind of anything we do, whether it's for substance use disorders or a lot of other medical conditions, or even raising your kids, which I have to make sure I reduce harm with them. And it's something I grew into. It is a spectrum of care. I would say, just like patients are on the spectrum of ambivalence, I also was. And so this, my little story here reflects how I am now, not how I was a couple years ago. So, the first step is just motivational interviewing and just talking openly with a non-judgmental, curious attitude about, hey, what are you doing and why? And actually before that, are you okay to talk about this topic? And so additionally, because it took a while to develop that therapeutic alliance with this patient, for him to talk openly about how he's injecting one substance when I'm treating another, because of his history of probably getting either kicked out of treatment or otherwise getting penalized for his comorbid polysubstance use. It took a while to get there, but we started talking about how he was using, and so I was able to talk to him about whether he was using unused injection equipment, and was then able to offer to prescribe him injection equipment, or at least make sure he's connected to harm reduction organizations that can provide him with such. He had insurance actually, which is pretty rare nowadays in North Carolina. I was able to assess whether he'd be a good candidate for pre-exposure prophylaxis for HIV prevention, and also like continually inquire whether he'd be interested in behavioral health care or even a higher level of care with IOP or what have you. He was not at that point engaging regularly with behavioral health here, and we do not require that for our opioid use disorder program or to get buprenorphine prescriptions. And it wasn't so applicable to him since he was really never using opioids once he was on a stable dose of buprenorphine, but I could also check to see if he, since he is using alone, whether he wanted to learn resources about neverusealone.com. If you're not familiar with it, you should Google it while I'm talking. It's okay, I won't see you. Neverusealone.com. There's also a phone number on that website for people that don't have internet. And just really just recognizing that people's motivation and experience and what's happening is a today thing. And so having the ability to check in on this, again, with an open, non-judgmental attitude at every visit, if he gave me permission to talk about those things, to me, that is how I employed harm reduction in my routine clinical care of, in this case, opioid use disorder and his methamphetamine use disorder. So there are a lot of examples of harm reduction outside of substance use care, and we often point to seatbelt laws. If you really wanted to eliminate motor vehicle accident deaths and morbidity, you would eliminate driving. It'd be a simple solution. And same with STIs and HIV. If there was no sex, there would be very little STI and HIV transmission, and yet that is not realistic. I think being realistic is a pretty big concept when it comes to harm reduction. But also that, hey, if we have this reality, how can we move towards better? We can't be absolutely perfect, but how can we move towards better and continuously reevaluate what the reality is, the potential for changes, and what the tools are at our disposal. So we have seatbelts, we have speeding laws, we have helmets for bicyclists, we have condoms and testing and prep for STI and HIV transmission. So when it comes to substance use, that can be applied quite widely. And there, I mean, we have as much as we could fit into our short presentation. I can tell I'm already probably going over time, but the possibilities are potentially endless to figure out how can we help make this patient in front of me safer and healthier without the requirement that perfect abstinence or perfect health is the end goal. So essentially it's meeting people where they're at and developing a relationship that's based on dignity and respect, autonomy and individuality. And so I think for me, it was great to hear the previous speakers today. I think the timing of our presentations was perfect in that harm reduction really takes into account the intersectional identities of our patients. That being said, I know myself, I am still striving to do better to understand the ways racial and ethnic and gender oppression affects my individual patients. And I think having an open heart and open mind about that experience is just as equal to the open mind about someone's history and relationship with substance use. And let's see. Yeah, and so there's, hopefully we'll go over some of the evidence of why all the big organizations, WHO, CDC, and what have you, support harm reduction interventions. Some have higher levels of evidence than others, but all in all, most harm reduction techniques do have evidence supporting reduction in morbidity, mortality, improvements in cost effectiveness, in some cases decreased crime and violence, and community health as well. So this is not just harm reduction for the individual in front of you, but for the community that person lives in. So these are some of the main examples of harm reduction in my clinical practice. So that's, I'm an MD, I can prescribe, I see patients in 20-minute bites. that have to get billed a certain way and have to do all the QI stuff. So it is tough to incorporate these elements into all the other demands of that clinical encounter. But you know, we've made it routinized, and it's essential part of the way I approach patients. So the first one I think is one of the most important because it has the best evidence behind it. It's one of the most cost-effective interventions you can do in substance use care, particularly in this country, which is having an overdose with opioids epidemic on top of this pandemic. So that's co-prescribing naloxone or connecting people without insurance to places where they can get that for free, often harm reduction organizations. North Carolina Harm Reduction Coalition is a great partner. And then Bela works closely with Study Collective, is one of the organizations we have here in Asheville. So, and I think I go over the evidence in a later slide. Then, of course, providing medication for opioid use disorder for people who have had a full assessment with a diagnosis of OUD. And of course, there's MAT for alcohol use disorder, and as we heard earlier, nicotine use disorders. All these medications, the FDA-approved medications, are very effective, particularly for opioid use disorder, though this country's main approach to opioid use disorder is abstinence-only approaches. That is not consistent with the evidence. Medication, even by itself, is a very, very powerful tool to decrease mortality, HIV and Hep C transmission, as well as continued substance use. It very quickly brings stability to patients' lives, so I can't overemphasize how important it is to prescribe buprenorphine for your patients and methadone when you're in OTP. So additionally, buprenorphine is just being shown more and more in research to be a very versatile, safe medication for more than just addiction treatment. So there is some smaller studies looking at buprenorphine for pain, not just in the perioperative setting, which is kind of how it had been traditionally used before it got elevated as a form of MOUD. So it's been shown to be as effective in certain cases as traditional full agonists. There's some discussion in the literature of, though buprenorphine has a ceiling effect for sedation and respiratory depression, it does not have the same ceiling effect for analgesia, especially when you're dosing it, you know, 3 or 4 times a day. So though you might not think, oh, buprenorphine for pain, that's reducing harm, it is, because opioids are inherently harmful. We know that it worsens pain over time. It increases risk for all-cause mortality, not just addiction and overdose mortality. It increased falls, increased central apnea, increased hypogonadism. There's a long list. I can keep going, but we have limited time. So just moving along the bottom row there, HIV and Hep C screening and treatment, but particularly treating patients with active use, whether it's alcohol use or injection drug use. This has been shown to be effective. I'm going to hold off on the evidence because I'm pretty sure I have it in later slides. And then to carry along with HIV, pre-exposure prophylaxis effective. And so these are all things I employ in my clinical practice. I'm assessing, hey, for patients who are struggling with using unused syringes and needles, are they candidates for pre-exposure prophylaxis? When I inherit patients from older prescribers, often retiring prescribers in this practice and elsewhere in town, and I'm inheriting these patients with chronic opioid therapy, I'm continuously having the conversation. Again, they don't have a diagnosed opioid use disorder. Maybe they don't even want to talk to me about it, but I at least introduced the idea, hey, would you like to talk about ways to make your pain management safer? There's new research. I'm a new doctor here. I'm maybe younger than the doctor you had before, but there's new research showing that there's a new medication, newish medication, buprenorphine, that can manage your pain, maybe even reverse some of the hyperalgesia and make it safer for you, if not more effective. And the last one is actually kind of, we put it last because it's sort of, again, expanding the envelope of what we consider appropriate substance use care or appropriate harm reduction, which is buprenorphine is overdose prevention. And in fact, a lot of illicits, the majority of illicit buprenorphine use is used in this way, which is essentially therapeutic or overdose prevention. So that's someone who is using opioids regularly, and but when they can or feel they will, they can use buprenorphine in place of their full agonist illicit or non-illicit opioid to stave off withdrawal symptoms, to make themselves feel normal, much the same way often those illicit substances can help them feel normal. And so that's a little bit, we make reference to it later, of low barrier access to buprenorphine. I would say this is something that's kind of, I'm still thinking on and evolving, of like how to make buprenorphine more accessible without the hoops. I think the pandemic has showed us that this is an important thing, as we've seen in North Carolina, overdose rates going up, particularly for the uninsured individuals, because we had an issue in some segments of our legislature with expanding Medicaid. So buprenorphine access has expanded in some ways with telehealth, as Dr. Finch mentioned and reviewed this morning. So how does this work? So in general, especially syringe access programs being the sort of standard barrier for harm reduction, these kind of things have shown, as we said earlier, to reduce HIV and hepatitis C transmission, increase access to care, particularly for the most vulnerable. When we are focusing on mortality, certainly doing a across-the-board all-population intervention is an important thing to do, but specifically targeting the ones in our communities who are at highest risk for mortality, morbidity, that's going to give you the biggest bang for your buck. And so these are individuals who may have unstable housing, usually have no insurance, usually have a lot of trauma, who may not fit so well into traditional, OTPs, or even my primary care-based OBOT program here, or even going to the health department, which, at least in Asheville, is close to the jail and the police department and things like that. It's hard for some individuals to engage in some of those levels of care, whereas harm reduction, particularly syringe access programs, are often the lowest barrier, but highest, highest impact source of care for individuals, which often can be a source of referrals to higher levels of care. And we're talking about the higher level being just seeing me. Or even just getting HIV and Hep C testing, which is a thing that is commonly done in syringe access programs. So I'm looking at our little bibliography that we put together researching for these slides. There's enormous amounts of evidence. Oh, and we have it at the bottom, tiny in the screen there. Enormous amounts of evidence supporting the cost effectiveness and the just general clinical efficacy of syringe exchange programs. So some of the things I mentioned on that previous slide. So medication for opioid use disorder has been shown to decrease mortality up to 70% in some references, but we use 50% here for some of the more standard references, and really works ideally if provided continuously and without cessation, which is tough, particularly for, at least here at MAHEC, for our postpartum patients when they lose their Medicaid, instead have to use the ER as a source of care, which is more expensive, of course, than providing this person with Medicaid, but I'm not in charge yet. So I mentioned buprenorphine for pain and some of the evidence behind that. Just to point it out more specifically, they've shown research trials, more like case series, where they converted folks from full agonist opioids, often with really high MMEs, like in the upper 100s to 200s, and converting them to buprenorphine for pain. The majority had either an equal pain score or pain control or improved pain score. And for the individuals who said, no, I can't do this, I have to go back to my full agonist opioids, they did not have improvement in their pain. So, not everyone can make that conversion, but for those who do, it's decreasing their risk and at sometimes improving their pain control. And so this is literally going to improve the number of years that they are on this earth. I mentioned co-prescribing naloxone, but just some of the research behind it, as we show right there on the slide, about 1 out of 50% decline in ER visits, a significant improvement in mortality. And so this is really important. When I prescribe it to patients, oftentimes I hear, oh no, I don't have a problem with that. I'm not doing that anymore. I think patients, and I think I'm still working on my messaging. That's probably the real story here, but oftentimes patients say, no, I'm doing good. Like, it's almost like I'm implying that they're not doing good, that I need to give them the overdose reversal medication. And I often say, hey, you are the next person that's going to save someone else's life. You, more than anyone else, can recognize another person in distress better than I can. You see it more often than I have. So I would love if you had this around. Medicaid covers it, and your insurance may cover it, depending on your copays and everything. So please, take this, or at least, talk to your roommates, your mom or dad, or whoever you're living with about it, because this is life-saving, and we know that based on experience as well as research. So we talked about HIV and Hep C screening, and I'll be for those who are joining my workshop in the next session. I'll be talking a lot more about HIV and hepatitis C treatment, particularly with someone with an active substance use issue, with active use. But you know, there's tons of evidence showing that just treating both those conditions without the details is cost effective because of the, of course, repercussions of untreated HIV and hepatitis C. But there's also what I would say is kind of old news now, that treatment is a form of prevention. If your HIV is virally suppressed, your risk of transmission is damn near zero. And then if you're treated for Hep C, of course, you know, if you're cured, you cannot transmit. So there was often conversations about the risk of reinfection of patients who have injection drug use histories, and a lot of states had you know, artificial barriers preventing, or still do have artificial barriers preventing Hep C medication access for patients who have active substance use. That is not reflected in the literature. These patients have equivalent, and in some cases, if they are linked to harm reduction resources, lower rates of reinfection than the general population. And so treating a person's Hep C is a no-brainer, and that's reflected in the AASLD guidelines. And in fact, I mean, if you had two people to treat, one person with active use, one person who's not actively using, to be honest, the person with active use is probably more cost effective, because then you're potentially reducing that transmission to the community. And then PrEP, you know, PrEP does not have as much robust evidence for the injection drug use population as it does for MSM and sex workers and some of the other trials in different parts of the earth. But there is in some smaller RCTs, a 70% risk reduction in patients, particularly who had good adherence to the medications to prevent. So though I do think about PrEP for my patients with injection drug use, I really emphasize the needle exchange, the syringe services. So that was a breeze through, and we still have a lot to go. I hope everyone's keeping up with me. I can't really see anyone, so roll your eyes if you need to, please. So what are some other harm reduction friendly approaches to particularly treatment of opioid use disorder? So urine drug screen should be an A1C. If you have someone with diabetes who says, "Doc, I'm using my insulin, I'm eating only fruits and vegetables literally all day, every day, and their A1C is 13, you don't say, "Get out of my clinic." Why don't you say that? Because you would be performing malpractice. That is insane to do that to a patient. And yet many well-intentioned medication for opioid use disorder providers do this. They say, "Oh, you have cocaine or methamphetamine in your urine. If this happens a few more times, you got to go somewhere else." Well, doc, I can't go somewhere else. I ride my bike to your clinic. The nearest OTP that you're making me go to for daily dosing is an hour drive away because I live in rural North Carolina. Well, tough luck, it's written in my policy. That is not appropriate for patient care. Those are patients who will end up in the ER, end up in jail, or end up dead. I mean, that's the true story here. So we really need to change the way we use urine drug screens, not as a point of penalizing or a gotcha moment, but as a way to have a conversation of, hey, what are you struggling with? How can we do better to meet your needs that you want to meet? And maybe you don't want to get there, and so we'll keep having the conversation. For me, one of the few reasons we will discharge or transfer someone's care elsewhere is if the person is a physical or some kind of threat to staff or other patients here, which is very rare and has nothing to do with their substance use issues usually, or if they are absolutely not gaining anything from the buprenorphine prescription, meaning like they're not taking it at all, and their urine shows no buprenorphine and they don't have a good reason for that. Even, you know, I might say, hey, take some right now and then like come back tomorrow and, you know, let's check your urine drug screen. And that has happened once in years for me. So, and I'll go through these quickly. I'm sorry, Bail, I'm using up our time. So home induction, this is pretty bread and butter, but the previous kind of guidelines from ASAM and the other guideline makers emphasized office induction. We know that's not great for patients who are going through withdrawal to sit in a room with fluorescent lights and a bunch of strangers outside the door, and you have to sit for hours. That makes no sense. Research shows home inductions are just as safe and effective as office-based inductions. We sort of touched on this, and we'll touch on some more. Buprenorphine, despite uncontrolled other substance use issues, it's still appropriate to keep them on buprenorphine. Not appropriate, it is the right thing to do because it's managing their opioid use disorder. Just like you can control someone's hypertension, even if their diabetes is out of control, you are improving their lifespan by doing so. Benzos being thought of as before relative contraindication of buprenorphine treatment. The newest ASAM guidelines that came out, I want to say 6-ish months ago, backpedal that even more, saying like, hey, this should not be an issue. If someone wants to work on their benzo use disorder, you can work on that. That is its own problem. But if someone's using benzos and buprenorphine, sure, they do have a higher than average risk of overdose, respiratory depression. But if you compare that to a full agonist opioid and benzo, that doesn't cut out. You're reducing risk by treating their buprenorphine. Let's see if I can skip any of these. I talk too much. Continue. Great. And then the last one, I really, really always say I love my behavioral health colleagues in MAHEC and anyone I've ever met. And I think behavioral health counselors are particularly important for patients, A, that want to engage in it. If you are forcing someone to engage in behavioral health, they're probably not going to get much benefit. And B, if people are trying to work on the underlying issues that either came before the substance use or manifested because of the substance use, often PTSD or early childhood trauma. And I'd like to include in that early childhood trauma those ACEs, adverse childhood experiences, as we learned this morning, issues of racism. So not race, but racism is the real risk factor here. So if patients want to work on that with an appropriate behavioral health counselor, that is a good thing to have in your clinic and refer people out, but should not be a precondition to get life-saving medication. So, so another harm reduction, I guess, technique you could say we utilize clinically is just really focusing on some of the highest risk factors for overdose, which is kind of like suicide, a non-fatal previous attempt of suicide, in this case, previous overdose that was non-fatal is the greatest risk factor for a fatal overdose. So really honing in on deciphering which of your patients are at the highest risk. And to be honest, I spend more time with them and at the sacrifice of all kinds of other patients. But I see myself as not only treating individuals, but my panel of patients and potentially the community. And so I justify, at least in my heart, that I need to spend more time on these patients with a higher risk. And so this is particularly people with post-incarceration and other criminal justice involvement. Those patients, as we know, actually from North Carolina data from some UNC colleagues, that those first 2 to 4 weeks out of jail or prison is the highest risk of any risk factor that we know of for overdose from opioids. But including alongside that is leaving hospitalization, leaving detox and rehab in some settings that I love my detox and rehab colleagues, but I think we're all struggling to find ways to start and continue buprenorphine in those settings. And since we're not there yet, I know that detox and rehab can sometimes be a risk factor for overdose. So being attentive to that and just trying to ensure that patients have continuity of their buprenorphine prescriptions. And sort of along those lines, hopefully I'm not jumping around. I meant to have more of a narrative flow, but I'm trying to rush here. But just like looking for ways to eliminate barriers. And so most of these barriers are man-made, whether it's insurance access or Medicaid expansion, whether it's you got to come in and do all these things and get a full evaluation before your first prescription. That's very difficult for someone who is experiencing withdrawal, experiencing this moment of their life where they're like, hey, I'm actually finally opening the door to having this thought to engaging in this care. And if you're like, cool, I'm going to give you an appointment in a week with the intake counselor and they're going to do an hour conversation, don't come in intoxicated. It's sort of like, what is that person supposed to do? Come in withdrawal and not get medication on that visit. So looking for ways to reduce those barriers, often that we've made in our clinic, that's a form of harm reduction in and of itself. And so there's some examples. One is in France when they deregulated the prescribing ability of primary care providers, mostly to prescribe buprenorphine, that within I think a year or two reduced overdose deaths significantly. And then we've seen even the first year after Medicaid expansion for states who had not done it, I guess years ago, they within that year saw a reduction in overdose deaths. I'll say it again, the biggest contributor to overdose visits in the ER are uninsured patients. So the argument that we are somehow not able to afford Medicaid expansion is based on bad arithmetic. I'm sorry to say that some people in our leadership in the state just are not doing so well in grade school math. So I'm a taxpayer. I really appreciate if we had Medicaid access for patients so they wouldn't have to rely on the expensive ER or worse to get the care that they deserve. And then the last thing is, I think I mentioned this there is evidence that, and pretty high quality evidence, that diversion of buprenorphine, whether in jails or prisons or in the community, is not being used for intoxication. In the streets of Asheville, for instance, 8 milligram strip of the combo product is about $20 or $30, and you know, a decent sized bag of, well, probably at this point, fentanyl can be about $20 or $30. And so if you're trying to get intoxicated, it's very easy to find the bigger bang for your buck. The folks who are buying buprenorphine on the streets are using it for therapeutic purposes. It's extremely hard, as I tell my patients, to overdose on buprenorphine. You have a better chance of overdosing on acetaminophen that you can buy, of course, at the pharmacy than you can from buprenorphine. So this is from a great document. Maybe I'll kind of touch on a few of these that I think are more important, but this is a great document from the CDC in 2018. You can see the references on the bottom. So one is the idea of targeted naloxone distribution. So really focusing, as we said earlier, the folks with the highest risk for overdose. So every person leaving jail or prison should have naloxone in their hand. That is a fact. Naloxone should be over the counter, in my opinion. It should be like water. I mean, it is that life-saving, and that, you know, you can't hurt yourself. There's no way you can hurt yourself with naloxone unless you, I guess, bite on the, you know, the nasal applicator and you know, the plastic cuts your mouth or something. It's very, very, very safe. Some of the other things, I find that North Carolina is actually pretty good with prior auth requirements. Maybe, I don't know if anyone's from Tennessee, hate to call you up, but Tennessee is a little different from North Carolina Medicaid with buprenorphine prior auth. So I feel pretty good about that in North Carolina. Which others? Oh, MAT in criminal justice settings. That's really important. That's been shown not only, of course, to improve engagement in care, post-release, and things like that, but there's some evidence it reduces recidivism and parole and probation violations, and even violence within the criminal justice setting, the jail or the prison. So, and same with ER. I'm actually, I don't think I did the research so hard on this, but it is in that document. But there are a number of programs, particularly with big academic centers. I'm pretty sure UNC does this at their ERs, of starting buprenorphine in the ER. It's a no-brainer. Why would you treat someone's diabetic ketoacidosis and say, see you later? Like, I'm not going to give you an insulin prescription, so hopefully you won't have to come back, right? That would be, again, malpractice by an ER provider, and yet we're still struggling to provide buprenorphine in the ER. So just to flip to another side of what harm reduction is all about, one of the most important factors of why a person will engage and stay in treatment is that relationship with a treatment team. That's been shown in research. And so access, both physically in terms of where the location is. We know from a study in West Virginia that the closest OTP was over an hour to drive for patients, whereas the closest FQHC was closer, so buprenorphine should be an option for those patients. But also the nearest dialysis center was like half an hour away. So it just shows what we're emphasizing in our spending as a culture in America, and where we're focusing our healthcare dollars and attention. But not just the physical access, but the, I guess you could say, spiritual, psychological, social access has to do with how patients perceive their care providers, whether it's me or the behavioral health provider, the front desk person, the person drawing the blood or getting the urine drug screen in the lab, even the pharmacist. So there is research around all of that, that when patients feel stigmatized or not treated with respect, they are less likely to engage in care, and that can have deadly consequences. So in short, you know, to succeed in taking care of your OUD patients and your SUD patients, the relationship is important, and empowering patients and educating them is essential. And part of that is, I won't harp on this for too long because this might be common knowledge to all of you, but language matters. There is research showing that the same providers reading 2 stories of the exact same hypothetical patient, but in one story using the language on the left, which is stigmatizing language, and then the other story, language on the right, exact same clinical scenario, these providers had different assessments and plans for those patients. So you might not think that it matters what you write in your chart, let alone how you discuss your patients in the break room or in the elevator, but this does matter because not only are you affecting the care of that patient when someone else reads your chart or when a learner is overhearing you if you're an attending and you have students, but you're internalizing those thoughts in unconscious ways of what this person is. And I would say, just to reflect back on my previous presenters, race and gender dynamics will play a role in this. So you gotta trust that you can't be trusted and that we should just use the less stigmatizing language for all patients. So, and then I'll just touch quickly, we're out of time, but just that naloxone, everyone should have it. You know, we try to encourage all of our medical residents here to have it. We had a third year, I think the year before last, that had naloxone because of one of these talks we gave and was actually pumping gas at the gas station near our campus here and saw a patient seemingly asleep in a running car, but then noticed the person was breathing very, very slowly, knocked on the window, the person didn't answer, called 911. After calling 911, opened the door, tried to, you know, shake the person. I might be rearranging the order of the details here, but shake the person, didn't wake them up, strong rub, didn't wake them up, got the naloxone out, spray in their nose, may have saved the person's life or at least some brain cells. So you never know when you'll need naloxone. I often, when I do this live, I ask people to raise their hand. Who knows how to do CPR? And pretty much everyone's gonna raise their hand. Who has naloxone? Less people raise their hand. And I would say, guess which one you're likely to use first, considering what's happening in your country. And hopefully people think about it and don't think I'm being condescending. So, so those are just summarizing summarizing points. I'm gonna stop there and turn it over to Bela. And I'll be controlling the slides, Bela.
Thank you so much, Dr. Shukla. I'll let you know when we're ready to move forward so we can go ahead and go to the next one. Thank you. All right, and that covered a lot of what is going to be immediately relevant for many of you who are seeing patients in clinical settings. What I'm going to do is try to very quickly give the broader overview and context of harm reduction on the ground in the community, especially from the perspective of folks that I work with doing the direct harm reduction work through community syringe access programs, and some of the research behind that. I may not go through all the slides that we have so that we can make sure we have time for questions and discussion. I want to draw people's attention to, I'm not going to have you read all of this, you'll have access to it later, but I want to just highlight where work in the United States and globally in harm reduction comes from. It is informed by a set of established principles. These are circulated and you would find them on the website of the National Harm Reduction Coalition. These principles, it's on this slide and the next slide that I'll jump to in a second. These guide evidence-based, community-oriented syringe access and overdose prevention work. So harm reduction, the key thing to get across here, I think, when talking about the principles of harm reduction is it's much more than handing out safe injecting supplies, safe consumption supplies. It's much more than handing out naloxone. So it's not just what we do, it's how we do it. It's very much guiding everything that we do in an overall understanding of harm reduction as a set of values and practical strategies that recognize the inherent humanity of people who use drugs. And that might sound really obvious, but often it isn't. In research that my colleagues and I have been doing with providers, with pharmacists, hearing about people's interactions with first responders, with law enforcement, that essential vision and understanding of people who use drugs as having the same dignity and rights and humanity as anyone else does seem to be the thing that is often lacking. So these principles remind us that the goal, oh, you can go to the next slide. I've tried to do it myself. These principles remind us that the goal of harm reduction is not to get people to stop using, but to facilitate access to resources that they need to live safer lives and to use safely. And also that people who use drugs are the ones who get to decide what they need in that regard. And so, you know, as Dr. Shukla was saying, so clearly before, this is not about telling someone what to do or forcing them to do something in order to get the thing that you think that they need or that they are asking for. It's really about trusting that a person knows what they need to be safe and to live as healthy as they can. One key tenet of harm reduction that I think is probably clear by now is that it accepts drug use as a reality, just as Dr. Shukla was talking about with the earlier patient example. If you know that somebody is going to continue using, how can you support them to use as safely as they can? And it recognizes use as a continuum. It's not all or nothing, that people are already adapting their use in different ways, whether that's by using fentanyl test strips and then changing their dose, using more slowly, making sure that they're not using alone. There are a lot of examples of ways that people are already making these decisions for themselves. And the fundamental premise of harm reduction, really where harm reduction started, especially in the United States, that informed the development of these principles is the idea of nothing about us without us. This is something I hear a lot from people who use drugs and those who directly serve them, that the focus should be on empowering people who use drugs to determine what is best for them, but with accurate information. So folks want the evidence-based information about what is most likely to reduce overdose, what is going to keep them safe, and then using that information, they want to be able to decide what to do. And fundamentally, harm reduction on the ground in the real world recognizes the structural circumstances that shape use. So it's a philosophy and a framework that guides what we do and how we do it. And I did notice a question in the chat about the term harm reduction and whether that's the right language. And I'll just quickly, we can talk about this more if there's time at the end, but I'll quickly say that the folks I work with who do this work increasingly are talking about harm reduction, not just as reducing the potential harm or negative health consequences of substance use when someone doesn't have access to safe consumption supplies, but really of reducing the harm and the negative consequences of the criminalization of substance use, reducing the harm of structural racism, which really determines who suffers the most from that criminalization. And so I think we can think about harm reduction more broadly in terms of not just reducing the immediate harm for the individual, but as Dr. Shukla mentioned, reducing the harm to the whole community. Next slide, please. And we won't go through all of these, but they will be in the handout. We'll pop them up again at the end while people are thinking about questions. I want people to know that there is an established set of harm reduction principles for healthcare settings. I think Dr. Shukla walked us through many examples of those and what that looks like. But if folks want to refer back to this and see sort of how do you feel like it fits with your own work with patients or clients, it might be really interesting. Next slide. So some examples of harm reduction specifically for drug use. You'll see a lot of overlap with the examples of how you could do this in clinical practice, but there are some that are perhaps not as available in clinical settings or not as available widely at all in the United States yet. Syringe access programs are the most well-known, the most well-studied. They are also proven to be the single most effective way to reduce overdose deaths. Something that we do not have as much evidence for in the United States, other than a recent study in the New England Journal of Medicine that evaluated an illicit safe consumption site, but we know globally that supervised drug consumption sites are one of the best ways to keep people alive. No one has ever died of an overdose at a safe consumption site. Fentanyl test strips are also a great tool. Hopefully, if you are not yet able to offer them to folks that you work with, that might be something to explore. What we're hearing a lot here in Western North Carolina is that there is already fentanyl in everything that primary opioid users are using. And so something that a lot of harm reductionists are doing is really trying to encourage the uptake of fentanyl test strip use among people who are primary benzo users or primary stimulant users, because we're also seeing when people do test their drugs that there's fentanyl in all of that as well. Shuchin already mentioned the Never Use Alone hotline. That's a great option, I think, especially during COVID, to let people know about that. We already know that people who use drugs, one of the best ways that they keep themselves safe is by using together. And when that's harder to do during a time of quarantine and isolation, this hotline is a way that someone can call, let a person at the other end that they're about to use, stay on the phone with them. And then the way it works is that your patient or whoever you're working with tells the person on the hotline whether they are willing to have 911 called if they stop responding, or they can identify another emergency contact if they prefer. Naloxone, you've heard a lot about it. We may talk more about it. Again, it is incredibly effective and everyone should have it. And then this last one, I know that this is maybe a little bit more controversial or harder, not as familiar for people to distinguish the difference between buprenorphine to treat opioid use disorder or buprenorphine as overdose prevention. What I do hear about from the folks I work with is that there are people who are not thinking about stopping using. They're not at a point where that's what they want to do, but they are aware that there's fentanyl in everything that they are using. Maybe they've been reversed recently or they've had to reverse an overdose recently. And so they now think of buprenorphine, whether it's something that they're gonna go and seek out for the first time during the pandemic because their supply is gonna be interrupted, or whether it's something that is being diverted, but it's being diverted to people who might otherwise die of a fentanyl overdose. And as Dr. Shukla said, if they can instead use diverted buprenorphine as overdose prevention from a harm reduction perspective, we think that's a good thing. I think, you know, we've already talked about this. You don't need to be further convinced, but there's very, very good evidence for community naloxone distribution, and I will leave it at that for now. Next slide, thank you. Syringe access programs, again, you've already heard some about this, but I think the main thing I want to highlight here is that in addition to reducing overdose deaths, reducing infectious disease transmission, increasing the uptake of Hep C treatment, and increasing participation in substance use treatment when it's available, which is an important caveat. It is hard for a syringe access program staff person or volunteer to refer a participant to substance use treatment if there is not any that is available, or if it doesn't have any open slots, or if it doesn't have any uninsured funding. So something to keep in mind when we're looking at, for example, in North Carolina, I think often a question that is asked of syringe access programs is how many referrals are you doing per year? And the folks I work with say that's really hard to answer when there's nowhere to refer people to. But a thing that does happen at syringe access programs is a lot of direct on-site health care. For many people who use drugs, the syringe access program is their primary or their only source of health information, guidance, or preventive care. We have syringe access programs out here where there is a nurse full-time at outreach sites doing wound care on site. Increasingly, we're starting to look at opportunities to apply for funding for there to be PrEP on site at syringe access programs, Hep C treatment on site at syringe access programs. There is a program a little bit to the east of us, but based in Hickory, where they're doing mobile Hep C treatment as part of syringe access outreach. So there are these models of bringing the care to people when people who use drugs, for the reasons that we went through already, maybe don't feel comfortable coming into traditional care. We can go to the next slide, thank you. Again, you can refer back to this on your own. We're not gonna walk through all of these, but I think sometimes people are aware of the syringe access law or aware of the Good Sam law, but not aware of kind of how many layers there are, how many iterations there are to some of these laws. There are actually more than just those two, or they've gone through a couple different phases. And there are some that actually supersede others or expand on others. So these are the laws that affect the patients or the people that you work with who are using drugs, and often they are not aware of them. This is also something we find a lot, that there's a lot of internalized stigma and fear that often comes from perhaps people not knowing that it is actually legal for them to seek safe injecting supplies, that it's not legal for them to try and return used injecting supplies. We have a lot of people that have been stopped, inappropriately arrested and charged for paraphernalia when that should not be happening. And so if we're not aware of these laws, it's hard to expect the people that we take care of to be aware of them. We can go on to the next. Thank you. And so one option that you have is to find out where there is a syringe access program or harm reduction organization near you that distributes naloxone. As you can see, there are many in the state, and there are even more counties served than what is reflected here. Many of these do mobile distribution beyond where they're based. And so I think one great thing, if you are willing and able to do this, is to find out the information for the syringe access program closest to you so that you can share it with other people, whether that's someone who is diagnosed with a substance use disorder and at risk of overdose, or you never know who might need this information. And Nidhi's chiming in that now there are 40 that are registered, so that's great. The good news is sometimes these maps get outdated really quickly. We can go on to the next one, thank you. And then this is just to try and share kind of a sense of the reach of these programs. Most of the registered syringe access programs in the state, not all of them, but most of them do have MOUs with the North Carolina Harm Reduction Coalition, and they get naloxone through NCHRC and then distribute kits that they make up with that naloxone. And so this map represents the kits that are distributed by syringe access programs that have agreements with NCHRC. And so maybe take a second to look at your part of the state and see how good the coverage is to give you a sense of what you might want to be encouraging or supporting in your area. And I think also the reach is probably broader than what's reflected here, again, because of mobile distribution that's happening. But this is something to know, that if you have folks who are having trouble getting naloxone at a pharmacy, either because they aren't comfortable going into one because of stigma, or they don't have insurance, they can't afford it, there might be another place where they can get it. Good Sam law, hopefully everybody already knows this, but anyone can obtain naloxone at a pharmacy without a prescription. So you can let your patients know, or people you're working with, that they can go in and request it. However, we do know that there are a lot of pharmacists that continue to be unwilling to dispense it. It's something that my colleagues and I are working on continuously. So it's good if you are able to know offhand to be able to tell a patient or someone else which pharmacy in your area is going to dispense naloxone upon request, and then also know where those SAPs are in case that's not happening. So in summary, hopefully we have given you some good reason to believe that harm reduction in all of its different forms as a philosophy and as a set of strategies and specific individual components saves lives, reduces costs, and that it can be integrated into your clinical practice. I hope maybe you leave today thinking of just one of the things we've mentioned that you might be able to add into what you're doing if you aren't already. And I know there are a lot of people watching that are already doing this. A lot of what I've learned about harm reduction has actually been from having the opportunity to spend time in OBOT programs where a lot of these things are already happening. So I'm grateful to the providers who model this. And next, we'll pop back up that side of the harm reduction principles for healthcare settings. Just to remind you, this is there. You can refer back to it. And I think there are already quite a few questions. Not sure how we're moderating the questions, but if you want to just go to the last slide just for a moment so we can acknowledge a few folks.
Yeah, and Bela, while you were speaking, I was trying to at least type in some answers. But so if people want to type in new ones, that's cool. But then we could go back to those. And I can choose some of the ones that were maybe worth a further conversation. Oh, there's probably a whole lot. Oh, there's a lot of things here.
And I would say feel free with the time that we have to maybe start with the more clinical questions given the audience, and then either of us can follow up and answer ones we don't get to.
Okay, let's see.
There's a lot of overlap. Some people put it in chat and Q&A.
Yeah, I didn't realize. So Bela, this might be more appropriate for you to answer. Harm reduction is too pejorative. It implies that there's no such thing as harm elimination. There is not. Any thoughts on to find a better term?
Thanks. Yeah, and that's what I was alluding to a little bit earlier when I was just briefly talking about the principles of the idea of what we are reducing the harm of. Is it specifically drug use, or is it this larger structural reality in which using substances is more likely to increase someone's risk of death or illness, which is much more the case in places where it's criminalized. We don't see overdose in places where substance use is decriminalized. We're a long way from there in the United States, but I think that's important to think about is what are we reducing the harm of? And otherwise, if we were going to find different language, personally, my training would be to pay attention to what people who are using drugs themselves, what language they use and what they're asking for. So there's a long history and really rich set of knowledge within the harm reduction movement. It has a long history, and so I wouldn't consider it my place to tell them to change what they call the work they do, but I think if it were going to change, it would come from the people they serve.
Yeah, and that same commenter thought, how about evidence-based medicine? Because of the evidence behind these harm reduction, or I'm sorry, I'm using the word, but for these interventions, so I appreciate that. I'm going to go back to one of these questions, but Michael Baca-Atlas asked, how would you prescribe BU for overdose prevention as needed? And Bela, you might need to remind me if what kind of evidence we found around this, but the way I would think of it is, I think a lot of it has to do with the comfort I as a prescriber would feel with how a patient knows how to use it, particularly when they might use it appropriately in the context of potentially daily other opioid illicit use, when they would use it and potentially cause withdrawal, like a precipitated withdrawal, when they might use it and may even lower their tolerance and thus increase their risk for overdose. So I think there is some way of doing it wrong for sure. And so I wouldn't feel comfortable unless I felt a patient understood really the pharmacodynamics of how buprenorphine works in the context of whatever the recent opioid use was and what the next opioid use was. So I don't think it's the best option for sure. I'd say it's more what I see when patients come in without insurance. I had a new patient who has a 15-month-old, is unhoused, and had a recent felony conviction, so has no benefits because of this conviction. And she had been using both heroin, fentanyl, meth, as well as buprenorphine, depending on what she had access to. And so, like, if you can think about the past months of this person, there was a mix of these substances. One of those substances is safer than the others, but depending on how it's used, it could also cause harm if someone is using the same amount of the same, fentanyl or heroin every day. That's one thing, but if you're using that some days and then buprenorphine other days, but then lower your tolerance and use that same amount of heroin, you could see how that could cause some harm. So I'd say it's not something I'm like, hey, well, you're using many things. Let me just give you what you want in terms of buprenorphine prescription. It's more of like understanding like, hey, patients may use this medication in different ways, and I want to optimize the person's education and understanding of how to do that if they feel like that's what they're going to do. What is your view of continuing prescribing buprenorphine in a person with OUD who constantly fails to provide urines, or whose urines are reportedly positive, or buprenorphine metabolites are negative? So there's a couple things there, and that goes back to another question that I think might have been about diversion as a reason for termination. So I wrote this in the chat, but probably easier to say out loud. If I feel a patient's getting benefit from the medication, which is specifically for OUD, it doesn't treat methamphetamine use disorder, it doesn't treat a whole lot of other things, but if it's helping with their opioid use disorder, even if I may suspect, hey, maybe they're sharing with their roommate who doesn't have insurance because my patient does, or maybe they are selling some of it because it provides them cash for food to eat. You know, maybe I haven't confirmed that because I haven't, you know, how would I confirm that unless I'm monitoring the patient 24/7? But if I had a suspicion that was happening, but I do know the patient's taking it, meaning they have buprenorphine in their urine and the metabolite in their urine, if I'm going that far with my testing, then I know they're using it and they're telling me, yeah, I'm not using other opioids because maybe the urine doesn't show other opioids. That is a person that should stay in care. That's someone who would be dying if you weren't taking care of them. I think it's different if someone clearly has no buprenorphine in their urine, or maybe they don't have the metabolite. Oops, where did it go? They don't have the metabolite. Those are patients I would talk to and say, listen, this is what I see in the urine. Can you explain to me why it looks like this? And I had one patient who basically gave water, and the reason was they felt they couldn't produce urine that day, and the next visit they were able to. Like, they were too, I guess, pee shy. I don't know the medical term for it. And so there's a reason. I could have just been like instantly blaming this person. This person was a young man of color who's had a terrible time with treatment in one of the cities in the Triangle. So was nervous about just the whole experience in a new clinic, and we were able to overcome it because I just asked openly and non-judgmentally. I could have been like, you failed your urine. The word failure, you are a failure. You got to get out of here. You're a criminal. That is a person who, again, could have been in the ER or jail or worse. So I think there's, you know, it's nuanced, and I'm happy to offline because I'm sure we're out of time, Sarah, but happy to take questions by email to discuss that further into different possibilities. Mayhec also does a ton of trainings around this, so we can talk further about it. There's a lot of questions. I don't know which one. Commenting on bup to norbup ratio. Ooh, I would love if someone else knew the answer. I think it's 10 to 1. It's either 1 to 10 or 10 to 1. I know it's a question on the addiction board I'm taking in a week, so I should know it off the top of my head, but yeah. And yeah, Baylor, thank you for your comments there. I think it's 1:30, Sarah. You feel free to call it.
You can do one more question. How about that?
Okay, I think there's, let's see.
Or maybe you've hit them all. You've been very productive.
I talk really fast. It's my years in New York. There's some Q&A. Thoughts of using Suboxone cocaine with cocaine patients. I ask if you're referring, if they have a stimulant use disorder only and using buprenorphine for that. I'm pretty sure there's no evidence for that. And if there is, it's anecdotal. Buprenorphine is effective clearly for opioid use disorder. I think there's decent evidence it helps reduce alcohol use in alcohol use disorders, but I have not seen personally any evidence that's helpful specifically for reducing stimulant use in someone with solo stimulant use disorder. My personal patients often will use methamphetamine, at least out west, when they can't find their opioid of choice. So I have seen people reduce that stimulant use if they're using buprenorphine, because then they're just feeling steady and not having cravings for anything. But so that's me just assuming what your question's about. So maybe I'll stop there, Sarah. I could go for another hour.
I'll call it now, but we will gather. They're still coming in, the questions in the chat, so we'll gather them all. We'll get them to Dr. Ostrick and Shukla, and then we'll share them with the entire group. So thank you so much. That was as you can see how engaging it was, a really awesome presentation.